I'm going to be talking about spinal stenosis. Lumbar spinal stenosis is the topic. So to start it all off, again, Hippocrates was quoted as saying, I guess attributed to, walking is man's best medicine. So to counteract that, what happens when we cannot walk? And so such a very prevalent diagnosis, something we see very commonly in our rehabilitation as well as orthopedics. And you've heard many topics already today about those limitations and disorders and conditions that affect walking in the lower extremity. Now we're going to kind of head up into the spine and talk about that. So my objectives again today, or not again, but definition and statistics of lumbar spinal stenosis, the evaluation and diagnosis, treatment, and if we have time, do some cases. Spinal stenosis comes, or stenosis really, is Greek for stenos, I guess you would say. It means a narrow or choke. It's an abnormal narrowing of a body channel, and it's used in many other medical conditions and cardiac, certainly, but in this case, for the spine and nerves and the cord itself, or the exiting nerves that control the peripheral limbs. It's very common, greater than age 50. You can see spondylosis or arthritis in 60% of women, 80% of men. Around 50% of men aged over 65 meet the criteria for having stenosis, but whether or not they have symptoms is a totally different story, and we've all seen that. We've all probably picked that up at some point. And another figure that's out there as far as epidemiology of stenosis is that 24 million have symptoms of cervical or lumbar stenosis. It is the leading preoperative diagnosis for adults older than 65 who undergo spinal surgery. To characterize it, it's an unpredictable course. There's flare-ups, stable periods, waxing and waning type of symptoms, and that's usually attributed to the various spectrum of this condition, and I'll get into that in a little bit. As far as the progression goes of this disorder or condition, there is one observational study, again, a very low amount of patients, but they were followed for 49 months, and they showed that 70% of the cases were unchanged over time, and 15% improved, 15% worsened. So you kind of just have this broad spectrum of how these specific population progressed through this condition and over a long period of time, which is hardly done. To review the anatomy about stenosis, just to kind of go over things, again, looking at the spinal cord and where it terminates in the lumbar spine, usually between the levels of T12 and L2. And when you talk about stenosis, it's those surrounding structures around the spinal cord that we talk about creating the stenosis or narrowing or choking of the nerves. And that narrowing can happen in certain areas of the spine. And when you look at that, when you see from the side view of the spine, you see the exiting foramen or foramina, and also looking down, or the axial view, you can see the vertebrae here. You see the spinal canal here, the exiting nerves have gone either side, the posterior elements, which are the joints, the spinous processes, and the transverse processes. And all those elements, again, make up the roof or contain or track of the spinal nerves. And you can have narrowing in any of these areas. So looking in the foramen, you can have narrowing there. Looking at the lateral recess, which is essentially the part of the spinal canal that's at the edge, and then the central canal here. So looking a little closer into it, we see kind of a pictorial view of this, where you can see that the canal itself, where the lateral recess is, or essentially the edge of the canal space, and where the foramen is and how the nerves exit outward. And in any of these locations, you can get that narrowing that occurs. So there, and I'll show you that in this other picture here in just a minute. But again, the definition, if you go back broadly and look at this and what spinal stenosis means and what it is a condition in which dimensions of the spinal canal reach a critical value, resulting in signs and symptoms. And it's direct compression. We know that it is some compression that happens mechanically and physically. We also know from studies that there is a part of this condition that is vascular as well, that there is a component where that compression becomes so much, and in certain conditions and positions of normal movement, that it compresses on it and it chokes the vascularity to the cord or to the nerves. So when we talk about the pathophysiology of spinal stenosis, 3 types certainly of stenosis can be congenital, acquired, or combined. Again, I talk about those 3 areas where the cord can be pinched or narrow: centrally, laterally, foraminally. There can be a combination of that congenital part of things where the pedicles can already be shortened, and that can cause stenosis, certainly at an earlier age. You see these pretty commonly, I would say, where they can predispose to a kind of a more rapid development of symptoms, as I said, at an earlier age. Very rarely do you see developmental stenosis and dysplasia as a possibility. Most of the time it's degenerative, this condition that happens. I'll talk about the stages of that in just a moment, but there is also a factor in part of having stenosis is spondylolisthesis, or a movement of the bone of the vertebrae, and that's pictured here, where essentially you have forward slippage of a vertebrae one on the other. This can be caused by small fractures, sometimes congenital, but also acquired or injury traumatic, and that can listhese the vertebrae, slippage forward, and cause stenosis centrally, foraminally in those areas. So to talk about the stages of what happens, of what we know, is it's this cascade that happens with stenosis. Essentially what you get in looking at this picture, again, kind of a picture view of what's happening, but kind of the beginning of what happens is that there is a repetitive microtrauma that happens, whether it's in through the disc, whether it's at the end plates of the vertebrae, and this disrupts the whole integrity of the system. And once that happens, very slowly and over time as a degenerative cascade, this fractures and it sets off certainly some tearing of the disc. The fibers within the disc can be torn. That causes some disc disruption, desiccation, where the disc can go essentially move backward, bulge out, become more larger, but actually smaller in size, less cushion. And that causes some bulging backward at the spine. When that happens, you get kind of an uncoupling or instability of these elements, and you get posterior elements trying to compromise for that. So the facets get larger. They're the supportive elements of the back. They get larger, they hypertrophy, they try to support more load because they have to take up that slack. And they get larger and can compress in this open space as well. So you can have compression from the back, the posterior elements of the spine as well. And you can see that in this picture here on your left, where the spinal cord, again, looking at the front and the back, and you can see a normal slice here, again, axial view, where the spinal canal nice and open. There is ample space there. Whereas when you come down further, you can see that the disc is bulging. There's facet hypertrophy. Certainly some osteophytes, again, can form off of that as well, because bone, again, is being laid down to kind of reinforce the spine. But that actually causes more stenosis, or narrowing of there. And you can also get hypertrophy of the ligamentum flavum, which is at the back of the spine, can also cause some stenosis as well. So looking at a patient's history, what they come in, they complain of, there can be a variation and a spectrum of symptoms that happen with lumbar spinal stenosis, and that is they have low back pain, certainly neurogenic claudication, which I'll talk about, but essentially just means that the nerves, again, are affected in the spine such that when you walk, you have pain. And that's really a characteristic of stenosis itself, is that You can't necessarily have stenosis so much in the definition if you're not having pain with walking. There's paresthesias that can happen. Certainly they have weakness. There can be foot drop associated with this. Fatigue, leg cramping, very commonly explained or complained of. And certainly radiculopathies can happen as well, where, depending on where the stenosis is, centrally, foraminally, those symptoms can, or a patient can complain of those things. So in the evaluation for stenosis, really a complete exam is done, neurologically, musculoskeletal, just looking at inspection, how their posture is, certainly how they're standing, what they do when they get up, how they hold themselves, how they walk across the room, essentially looking at their back, palpation, range of motion, certainly worsened pain with extension is certainly something that they have. Muscle strength in the lower limbs, sensation, reflexes, something like a Romberg maneuver can be a little helpful with balance and motor. And special tests certainly to look at for radiculopathy, neural tension, cross straight leg raise as well, a slump test where they're bending forward and doing a straight leg raise that can exacerbate symptoms from a nerve compression or neural tension. Femoral nerve stretch test as well can be helpful. But sometimes these may be normal. Sometimes they don't have those symptoms at all. And a lot of the times, as we see, sometimes none of this is positive, that they have a pretty much completely normal exam. They may have those subtle things though, and you can pick those up a lot of the times, where they're walking slow, their gait's kind of wide-based, they're kind of unsteady. And those are kind of more the dynamic features of this that I think you need to kind of watch and be careful and pay attention to, I think, because on a static exam, they could be totally normal. Another thing that's important too that I found, certainly in looking at this, is their peripheral pulses, their skin, their hair exam, certainly in the lower limbs, any swelling. Maybe they have vascular insufficiency as well. So that's important to pick up on because this is a mimicker of this condition, obviously, and it's something to kind of sort out, is do they have vascular claudication? And features of that really, to kind of set it apart, sometimes it can be very difficult. But looking at their skin, certainly their pulses, as I mentioned, lower limbs, checking a good vascular exam, and same things like this, so just easy questions to kind of tease out from them is, have there been skin changes, but certainly what's the time of their improvement of symptoms? And things like as well as when you ride an exercise bike, do you have symptoms? Well, when you look at this comparison chart, again, those are the things that kind of stick out to me is on an exercise bike, they're going to be positive, it's vascular, it's very painful to do that exercise. Whereas neurogenic, they're going to be fine. They're in the flexion, usually sitting down, right? And they're going to be able to ride as long as they want, usually, without pain. The other possibility too is sometimes it's a little bit unclear, but them standing can be fine for somebody with vascular claudication versus somebody that's standing up. They have to either sit or they have to bend forward to feel better with neurogenic claudication. So just some thoughts, certainly some things they probably know. To diagnose spinal stenosis, usually, as I said, sometimes physical exam is really inconclusive. People can be pretty normal on exam and still have stenosis. Imaging, really diagnostically, that's the way to diagnose it. Either an MRI or a CT myelogram are the diagnostic tests that we use to get this diagnosis. Sometimes, but I would say probably more rare, is picking it up on an EMG. You can see subtle changes on an EMG to, not necessarily make the diagnosis, but things can be a little bit abnormal on an EMG to look at that. Now, the things we worry about too as far as making that diagnosis, and certainly for red flags that arise when we're doing exam and something comes up or other symptoms that we see on a patient, are these two diagnoses that we look for all the time and we're very concerned about because of more urgency to it, and that is cauda equina syndrome and conus medullaris syndrome. which are in the categories of myelopathy and spinal cord injury. And really the keys to these, again, are there limb weakness in both limbs, bowel and bladder are affected, maybe some erectile dysfunction, they have saddle anesthesia. A lot different, obviously, we're always checking for those types of things because they may need immediate decompression. Conus medullaris, a little bit different. It's a little higher up. It involves usually that lowest part of the spinal cord and hits the upper motor neurons, so they get those symptoms of spasticity, certainly like a spinal cord injury, essentially. Could be a fracture, certainly trauma, a tumor. A tumor that can affect that area of the spine, and those things to look for, but it could be a mixed picture of myelopathy and radiculopathy for this syndrome. So kind of closely related, depending on where in the spine you get the issues, and certainly we look for those red flags. Now an MRI, when you look at an MRI, which is our diagnostic gold standard to try to look at stenosis, it's very sensitive. You can look at, certainly the views that you get. We look at certainly T1, T2, axial, sagittal, to kind of look at the different areas where you can get the stenosis centrally, foraminally in the lateral recess. And you can use measurements that can be correlated. Certainly those are done all the time with, certainly radiology would tell you. If you look here, again, normal, comparing this wide open space with the vertebrae and the discs and the spinal canal, the nerves coursing through, looks fine. Then you look at something like this, which you can see a little bit of spondylolisthesis at L3 to 4, and you look in the back here, and certainly on axial view, you can see that there's crowding, there's a disc bulge, kind of broad-based, as well as a ligamentum flavum, and they have some shortened pedicles as well there. And you can kind of see that central canal is narrow, the lateral recesses as well. And from a side view, you can also pick up foraminal stenosis on the MRI there, looking at kind of where they exit. So certainly the fat around the nerve there in the foramen, and as you look down here, you don't have much signal there that essentially said that's severe stenosis there in the foraminal view. So when looking at an MRI, I put this slide up before, but this one essentially shows that there are degenerative changes in the spine on imaging that are done from a broad population of patients with no symptoms, and it can be age specific. So as you see here on the top, you see your age. That as the age goes up, you certainly see all of these changes going very high percentages of time where you have disc degeneration. Disc bulging, protrusions, even spondylolisthesis, where all of those things go up as you age, which can be very normal. But again, so MRI being the gold standard looking at stenosis, it's important for us to put the two together in looking at an exam and a patient and their symptoms and correlating it to what you see on the imaging. So moving on to the outcome, this was a prospective study. There was a lot of centers involved, 270 patients in Japan. 30% of patients in this study did well with conservative management. They had radicular symptoms, less than a year. There was no spondylolisthesis or scoliosis involved. They picked out certain factors that was important to them to see whether or not how they did, or the outcome. And things like depression, cardiovascular comorbidity, impairment in their walking, scoliosis were kind of poor, attributed to the poor category. The better outcomes were people that had better walking ability, their health was better. And these are pretty obvious things, right? But kind of solidified some of those things that we know in trying to see who does better with this condition and who doesn't. As far as the treatment goes for stenosis, so obviously, as Dr. Oliver said, I do non-surgical treatment of this condition, and certainly the first line of, and certainly a lot of the evidence behind, is trialing medical and rehabilitation for this condition. And unless there is urgent or emergent indication, red flags, things that come up as I mentioned. And those things are progressive neurodecline, how quickly things are changing, how timeline and duration of symptoms. Is there a cauda equina syndrome? Is there a neoplasm or is that something to think about for moving things along a little bit quicker, obviously moving things towards surgical treatment. So looking at the treatment, things that are acute, the acute phase of having stenosis, again, it's usually not that way when people present with stenosis, right? It can be to a point if it's more radicular symptoms into the limb and they complain maybe of a foot drop, sudden onset pain, numbness, weakness, where it becomes this acute. And certainly there can be any spectrum. Obviously, you can have changes in the spine and have stenosis and also have a disc herniation, or also have something else impacting that nerve and causing the problem. I have a case like that I'll show you. But for acute management of this condition is activity modification. Again, avoiding those things that are painful. Medications, again, to help with inflammation, to calm down nerves, relax muscles. Sometimes steroids as an anti-inflammatory can be used. There is a little evidence to support that for radicular symptoms. Subacute-wise of managing the condition, all about rehabilitation. To what point do you do that? It's really hard to say, but getting these people involved in a rehabilitation program is pretty key. What I do, anyways, and that relies on a lot of exercises that are more flexion biased, helping with posture correction, strengthening core, preventing their extension, preventing those symptoms or those keys that certainly cause more symptoms to them. And those can be done to help them subacutely, but also acutely and chronically. So that's kind of a rehabilitation approach. A lot of us are in this room are familiar with that. And starting that early and what time frame, it depends on the individual and the patient and what they're willing to do. Certainly that's a big key. Using braces in stenosis. There is some evidence, really mechanical support, but there's also some evidence to support that you shouldn't necessarily do it all the time, that you can cause some weakness. But for those that can tolerate and that it helps them, there is evidence that this can be a method, and it's actually in some of the guidelines that are out there. But putting them in slightly flexion, being mechanical support, as I said, helping them be upright and lifting, and really aiding them in walking. Next is injections. Injections to help with radicular symptoms, certainly. Using fluoroscopic guidance is key with those injections, help calm down inflammation acutely. Somewhere in the line of 3 weeks to 6 months is kind of where symptomatic relief, it's really a short-term method of treatment, but can be very helpful for many, many patients. And whether or not there is some conflicting evidence regarding the efficacy, as I said, and the length of time that it helps people, but it is one tool and one treatment method that can be used to help this condition. Surgical consultation is, after that to decompress the spine ultimately, and sometimes certainly that progresses quickly or takes time to get to that point, failing some of these conservative treatment options, and that's what Dr. Leckie will talk on. What I've seen, and certainly this study is a good one, that looked at spinal stenosis and sciatica. They looked at injections. They looked at fluoroscopically guided injections to see how patients would do in that setting, and they found that 75% of patients receiving injections had more than 50% of pain reduction 1 year following the injection. Majority of these increased their walking and their tolerance for standing. And just adds to some of the evidence that we have behind using injections as a treatment option for many people. And then there's the chronic treatment. And again, all of these could be added in to try to help this condition chronically, but alternative treatments could be tried. Again, there's not convincing evidence behind some of them to use them, but there is enough. Certainly they can be used for certain situations. Medications, other lines of medications as far as the levels of treatment and different mechanisms of trying to help the pain are things that you can use. Certainly I could add rehab in here again, injections in here as well, as to try to help this condition and treat it. So finally, I finish up with some cases. I have a 62-year-old male. I saw him initially last year for back and leg pain. It had worsened really over 1 month's time. It was pretty progressive. This is what he drew for his pain diagram. As you see, sharp pain, which is red, along the back and buttocks, achy, more achy pain in the thighs and knees. Did have some more in the calves that he didn't mark, but he had mentioned to me. Didn't have much in way of numbness or weakness, but only when he would stand and walk, his symptoms came on. He tried a number of things before seeing me, including chiropractic treatment, home exercises, anti-inflammatories, a Medrol dose pack, opioids, still no relief, none. In a lot of trouble. At this point, very limited, very depressed, unhappy about his state. When I saw him, look at him again, full neuro exam, pretty normal, no deficits, able to do most things. But when you see him have him stand up and walk, he's hunched over, he can barely make a few steps, he's holding on to things, he's just not sure of himself, and he has a lot of pain doing that. MRI was done. Sorry, it's pretty dark. I apologize. I tried to get it still detailed, but it doesn't show exactly what I wanted to show. But he has a congenital stenosis already, he has shortened pedicles, he has multi-level involvement, but at 3 and 4, he has a disc extrusion that you can kind of see, if it was a little bit clearer, I apologize, is central but broad-based, and it also extended inferiorly along the posterior vertebrae and narrowed his canal space even more. So as I mentioned to you, you can have stenosis, but you can also have the acute disc happening as well, causing this type of a syndrome. Again, this guy was in a lot of pain. So started him in rehabilitation with some exercises to begin with to try to help him correct some of the posture, some of the walking, used a gait, a cane or a walker to try to help him with that limitation. And we got him in for an injection. And he did very well. In fact, complete relief of pain for about 10 to 11 months later. I saw him again. He was doing great. As I followed up with him, I saw him over time. He did end up coming back in, had very similar symptoms to this, not as acute though. And at that point, he was actually having more distal limb symptoms, difficulty walking again. And at that point, it was kind of more towards the stenosis part of things that he was complaining about rather than acute disc herniation on top of stenosis. And ended up trying another injection for him again, same result. He got very good results, immediate pain relief, able to walk, functioning well, doing all this rehabilitation, and doing very well to this point. So again, I mentioned that it's a good outcome as far as treatment of this condition, certainly an acute disorder on top of a chronic issue for him. As opposed to another case, which I saw, kind of similar. He's a 74-year-old guy. He presented in the emergency department in November last year, very severe back pain, more of a radicular picture that he was having kind of in one limb. 1 week of just severe pain, could not move, couldn't stand up and walk, didn't have an injury to it. He was doing well before. He had no problems before, never had an issue like this. And he was just unable to stand. So he was admitted for pain control. I saw him in consultation. Really no red flags. An MRI was ordered, and maybe you can see this a little bit better, but he had severe stenosis at above the usual level as well, same as the other patient that I showed you. But up here, 2 and 3, he had severe narrowing central canal, also congenitally short pedicles, but really crowding that space. And initially, he actually was managed pretty well with medications. He was able to go home, did a lot of rehab to get himself back. We did some injections to help with some of the radicular pain. And he actually responded pretty well to a lot of that treatment. And he was doing well. He actually continued. He had some recurrence of symptoms probably a few months out after this. Again, we did another injection for him. He had been continuing in physical therapy and really minimal medications for him. And ultimately, he didn't do, he had some recurrence after that, probably several months later, and was starting to kind of get progressively weaker. And so I sent him to my colleague, Dr. Leckie. And as what I hear, he had a recent operation doing pretty well. So again, just kind of show you the spectrum of what can happen. One case certainly doing well with a lot of conservative management. Certainly, I think he'll do pretty well for hopefully the time being. And another case where you have more acute symptoms, did pretty well for a little bit of time, but ultimately ended up needing a decompression to treat this condition. So, along the spectrum of trying to treat this, it can be managed. I think the bottom line that I can tell you with this is that many patients do very well with this condition with conservative treatment. And those things I mentioned with a combination, as long as looking at the whole person, deciding certainly what they can do, and with their efforts and everything that they can provide, I think you can do pretty well for this. There is one study, just to kind of quote it out there, that also is in some of the guidelines that states that between anywhere between a couple of years to sometimes even 10 years, patients can go with conservative management even after the onset of symptoms and do pretty well for that time period. Obviously with frequent monitoring and making sure they're doing well in their participation, as I mentioned. So that's about it. I have my references here, and thank you.